What keeps you going?
um, my family, my wife, and my sons, just in general. And then what keeps me going on a professional level, because some days it's hard, is those interactions I have with kids where um, I come into the room and they don't want to even look at me. And then by the end of the interaction, I'm getting a high five and smiles, and the parents are saying, "Oh, it's never had a visit with a doctor like this before."
Mhm. Hi, and welcome to Nothing is Rocket Science. We have Dr. Jonathan Heiman with us. The nerd pediatrician. So get ready to hear all about vaccinations and viruses and all the myths and misconceptions surrounding these topics. So welcome to Nothing is Rocket Science, Jonathan. It's great to have you.
Thank you, Sunday. I'm really excited to be here, and I've been checking your podcast out since I found out about it about a week ago, and I'm excited to be here and to meet you.
Likewise. So before we start off, the pediatrician. How did you come about that moniker? Is that what your patients call you, or is that something you gave
I
yourself?
wouldn't mind if they did. No, I have always sort of self-identified as, a nerd. And
Okay.
I have three sons, and they're all very uh, studious and into sports and things like that too. But for a long time in our family's been this kind of joke that, the term nerd is not a derogatory term.
Mhm.
And so I've kind of come into this desire to get into health and science communication through my work as a pediatrician.
Mhm.
And the YouTube channel I created about a year ago, made two videos and then stopped, kind of ran out of steam. But I was trying to find something catchy to call it. And my wife helped me come up with that one, and it just kind of stuck. So
No, that's great. Yeah. What you know, talking more about all of these things, what got you interested in pediatrics? Like, did you always know you wanted to be a doctor and work in pediatrics?
didn't always, well, I kind of came into medicine. In high school, I was very much into sciences and initially thought I wanted to do engineering or something like that.
Mhm.
And I'm not terrible at math, but I took calculus in high school and was like, yeah, I can't, that's about it. I can't go much further than that.
I hear
And
you.
at the same time, I took an anatomy and physiology class still in high school and had a wonderful teacher. And it was really the first time in my life that a subject captivated me in that way, that it was just so interesting to learn about physiology in the human body. And kind of from that point on, I thought, well, medicine, that makes sense. And so I was kind of tunnel vision from that point on. Went to medical school, did not even think about pediatrics initially.
Mhm.
And so in your third and fourth year of medical school, you do what we call the core clinical rotation. So
Right.
internal medicine or adult medicine, pediatrics, OBGYN, and then general surgery.
Mhm.
And I kind of liked everything, didn't really know what I wanted to do. Um, in retrospect, I really loved pediatrics, but I sort of talked myself out of it. And people said, "Oh, the parents, they're so difficult to deal with," and pediatricians are sort of known to be the lowest paid doctors. And so I
Oh,
didn't really know what I
interesting.
wanted to do. And actually, I went into radiology initially. So I did what they call a preliminary year in internal medicine. That was my intern year, matched into a radiology program. And 6 months into my first year, realized I was just miserable. And all of the things that I learned in med school only applied, in my opinion, kind of a very small amount. And there was a whole lot of physics to learn. And most of my day was spent sitting in front of a computer reading films, and I missed at that point the patient interactions. So I was lucky to have some connections back in New Orleans at the school, my medical school at LSU, and was able to transfer after that year into a combined residency in internal medicine and pediatrics. And then, so I had 3 years there. And after about 2.5 years, I realized I didn't really want to work with adults anymore. And I just really loved working with kids, and even the kids that come into the hospital because their parents aren't giving them the medication that they need to or whatever. I realized I could always have compassion and sympathy for the child, because it's not their fault if their parents weren't necessarily doing the right thing. So after graduation, I decided to focus just on pediatrics.
You told me when we were talking and through our email exchanges that adults are not, you kind of had it because the adults were not compliant with their medicines and stuff. Now that you've seen both ends of the spectrum, do you think pediatric patients are more compliant, or is it because the parents become compliant or the adults become compliant when it concerns their children?
Mm-hmm. Maybe a little bit more, so in most instances, until you're talking late adolescence, it's up to the parents, right? It's not the
Right.
child who's compliant or not compliant. My experience in residency now might have been a bit of selection bias. I was working at a university hospital in the inner city in New Orleans. And what frustrated me was if I was in clinic or if I was admitting a patient for heart failure, have them in the hospital for a few days, send them home and say, okay, you need to follow up in clinic on this day, and you need to take this diuretic and, follow this diet. And then a week later, they'd be back in the emergency room, and I'm readmitting them again, because there's only so much that we could, once we tell them, okay, here are your medications, this is what you need to do. And some of them sure were compliant, but other ones would come back in. It was like a revolving door, and it just got frustrating. And I didn't really, I didn't want to have to practice that kind of paternalistic medicine. In my opinion, my job is to provide the education and the resources and say, hey, look here, this is what you need to do. But once they walk out the door, I can't be in charge of that patient anymore.
Right.
So in pediatrics, certainly there are parents who fall into that category. But again, with the child, it's much easier for me to not have that compassion fatigue, because I can always have sympathy for the child. It's not their fault that their parents aren't necessarily taking care of them or giving them the medication. And then, certainly there is a lot of disparity, even in the United States, as far as socioeconomic status and resources and things like that. And the company that I work for, probably 95% of our patients are Medicaid, which is really good insurance. However, these kids still, a lot of them live in rural areas, and they don't have access to. So right now, mental health is a big one. So counselors and psychiatrists and things like that, getting these kids the resources that they need can be a struggle sometimes.
That's interesting. Yeah, it's never a simple answer. It's so multifaceted that it's very difficult to actually give a simple answer to these kind of questions. But yeah, so let's dive deep into today's topics, because I have several questions for you. First things first is vaccinations. In my experience, it's been a great conversation starter in the last few years. But as a doctor, why do you think people are apprehensive towards vaccination? Do you think adults are apprehensive if they have to take, or are they less apprehensive if they have to give it to their child, or especially the ones during infancy? So why do you think there is an apprehension towards vaccination?
Yeah, well, I mean, look, it's certainly multifaceted. And I would say, most of the parents that I see, they don't have any questions. Say, hey, your kid's due for XY vaccine today. Okay, but I have noticed that in the last several years, since the start of the pandemic,
Mhm.
that it's still a small percentage, but the number of parents that either don't want to vaccinate their child at all or excuse me, are hesitant to follow the recommended schedule, and they might say, well, I want to do this vaccine and not this one, and I want to space them out and things like that, has certainly increased. And it's interesting, I read a study uh, just recently by sorry, who put it out? The Kaiser Family Foundation, that said a recent survey said that about 35% of patients, or parents rather, they oppose school mandates for vaccinations. And school mandates in all of the states is really what got us to our current level of seeing, all these diseases like polio and measles really go away
Right.
in recent history. But it's interesting because those same parents, when polled, 80% or so of them said that they feel that the vaccines are confident and effective. So there's that nuance there where I think that it's the parents really want to have the right to choose, right?
Mm.
And not even just in vaccines, but I have seen this in my practice where there's so much more readily available information because of the internet compared to like when I was a child and going to see a pediatrician, and some of it's good information and obviously some of it is not good
Right,
information.
right, right.
So the idea where the parents want to be in charge, which I respect and I get that, but I always ask them to look, please just seek out good information. Let me, answer any questions or concerns you have. So certainly since the pandemic, I think the COVID vaccine really is where we started seeing a lot of hesitancy, a lot of distrust for the government. I spent, I was following along the vaccine development.
Mhm.
I was one of the first people in the state to get the vaccine because I was a healthcare worker. And
Right.
so by the time it was offered to me in late November of, I can't remember what year that
20,
was.
2021, 21, I think
Yeah.
so. Yeah.
Um, I had read everything about it and I felt very comfortable. And I spent a lot of time talking with, when we had the Delta surge, that's that late
Mm.
summer, where it just seemed like everyone had COVID. I spent a lot of time talking with not just my patients and their families, but friends and acquaintances.
Right.
And I would have, friends or friends of my wife's that maybe I didn't know that well that would text and say, hey, look, I was going to get the vaccine. This is before it's available to children, but my doctor said that they weren't sure. And now I'm confused, right? So I spent a lot of time, listening to the concerns of people. And a lot of what I heard was, it's so new. It was developed so quickly. How can it possibly be safe?
Mhm.
Those were kind of the main things. And
Right.
then you had the outlying things like, I'm hesitant to call it conspiracy theories, but certainly that's what they were, like it
Yeah.
makes you magnetic or whatever, like,
Mhm.
or the, the microchip, you're injected with,
Yeah.
right. So the
Yeah.
more, reasonable objections, I guess I heard were, again, the time course that it was developed, which was admittedly incredible. And the reason, there's certainly a lot of reasons that it was able to be developed so quickly, but one of them was just the huge amount of money and resources that the government was able to throw at it. But the second one, and the more yeah, one that makes most sense to me, is that the concept of mRNA vaccines was already established. They were using that to work on Ebola vaccination and a few other things. So that part was already pretty much done. And we call that the vehicle, right? That's what delivers
Right.
the information from the COVID virus to our body. So that really shortened the time course. And they tested these on tens of thousands of people before they released them to the general public. So by the time it came out, I was ready to get it. And I was telling everyone, hey, I got it, you know. And then when it was approved for the ages that my kids were at the time, we were, you know, the first day that we could go get it, we got it at a Walgreens. And I was telling everybody, you know, you got to go get this. So I think that was a big influence on the amount of vaccine hesitancy that we've seen. And I was reading a CDC study just this morning talking about childhood vaccination rates on a nationwide standpoint. And so they were looking at 4 recommended childhood vaccines. So that's the MMR, the DTaP, the polio, and varicella or chickenpox. And so in 2019 to 2020 school year, if you average all of those across the nation, we had about a 95% coverage level, which is where we want to be. Measles is highly transmissible. So when we look at that one and we say, look, we need to have about 95% of the population vaccinated in order to affect herd immunity to protect the kids that are medically fragile and for whatever reason are not able to receive the vaccination. So 2019, 2020, we were about 95%. And then 21 to 22, it was slightly lower than 94%, which was the same for the 22 to 23. So we're talking about 1% difference, but that can actually make a huge difference clinically. And we've seen some outbreaks of measles. There was one in Ohio. I think it was in 2019.
Right.
So we're starting to see we're starting to see these old diseases pop up again. And I've never seen a case of the measles, right? You know, pediatricians that are 20, 30 years older than I have, sure. But if that walked into my clinic, I would be having to pull up a book or, you know, an internet article and look at the rash. Oh my God, is this really what I'm seeing? So it's an interesting time to be practicing medicine.
In one of the articles that you've written, you also mentioned that, like the flu and there are about 20 in 2022, 23, about 21,000 people died due to influenza. So when we use these numbers, it seems like they're dying of cold. So when you say flu, people just have, you know, just all they think of is cold and a little bit of fever. So what are these complications that are actually leading to death of people and in such high numbers?
So you're right. Generally speaking, the flu is a bad cold, fever, body aches. You feel bad for 5 or 7 days. Now, there are certain populations that are much more vulnerable to not only really severe disease, hospitalization, potentially death, and then also the complications that can have long-lasting effects, if not immediately acute effects, put you in the hospital sort of thing. So off the bat, we think about really young patients. So children less than 5 years old, less than most of these complications or severe disease occur in kids less than 2 years old. And then under 6 months is really where we see that high complication and morbidity rates. Now, on the other end of the spectrum, we have the elderly population. And, you know, it's really the same reason at opposite ends of the spectrum of life, in that when young children are born, even when they're full term, their immune systems are still developing. And so they can't fight off infection as well. And then we see the same thing, you know, in our elderly population. The other cases where we see complications and severe disease is people with certain chronic health problems. So asthma, COPD, coronary artery disease, diabetes, you know, and these are all things that a lot of our adult populations in the United States have as almost as a matter of course. So the way that I explain to my friends, family members, my patients' parents, is that the flu vaccine is not perfect, right? And because of the way that, we have multiple strains of the flu virus,
Right.
and they mutate and go through what we call antigenic shift and drift every year. So when the vaccine scientists make the vaccine for the upcoming flu season, they're looking at last year and the year before that and what was the most prevalent, and trying to make an educated guess on, okay, this is what we should include in this year's flu vaccine. And some years it's very effective, and some years it kind of misses the mark. So what I tell them is that getting a flu vaccine, certainly it's not 100% effective. It doesn't mean you're not going to get sick, but it
Mhm.
is still effective at preventing that severe disease, the complications, hospitalization, and death. And so if I'm talking to a parent of a healthy 5-year-old that doesn't have any of these called comorbidities or other medical problems, most of those kids will do just fine. But certainly there are children that progress to severe disease and severe morbidity and or mortality that were otherwise healthy kids to begin with. So in my mind, the flu vaccine is a very safe option to, instead of rolling the dice, say, hey, look, let me protect myself or my child as best as I can.
Mm. And there's also a lot of misconceptions around these vaccines, right? Like
Yes.
they contain
Yes.
unsafe toxins, or they cause autism, and like everything. Um,
Hmm.
how what do you think are the most common misconceptions that you've probably heard in your clinic, and like how do you address them?
Yeah. So just speaking about the flu vaccine, there are some very common ones. I hear almost every day during flu season, oh, I don't want it because it gives me the flu, right? And
Yeah.
so, first of all, there's a no, it doesn't work that way. The flu shot is not made from a live vaccine. Now the inhaled, the nasal version, which is much less commonly used, at least in my region,
Hmm.
is made from a live vaccine, but it's what we call an attenuated
Right.
virus or a weakened virus. So even that can't give you the flu. I think that myth or that misperception is um, uh, continued because of a few reasons. So, number one, it takes about 2 weeks for really any vaccine, and in particular the flu vaccine, to be truly effective. We're giving these vaccines during cold and flu season. So, you get a vaccine on the first of the month, and you're not fully protected until maybe 2 weeks later. So, you might just have the bad luck of getting the flu 3 days later, being around someone before you're protected from the vaccine. Or you might get another respiratory virus. So the rhinovirus, right, the common cold virus. All of these respiratory viruses have such overlapping symptoms, and even now COVID. So
Hmm.
you get sick and you think, oh my gosh, I got the flu. You know what? I got the flu vaccine last week. I must have got it from that, right? And then,
Right.
in my experience, the last thing is that anytime you get a vaccine, it just has the potential to make you just feel kind of bad for a day or so. So um, the low grade fever, the achiness, just not feeling great is actually a sign of your body's immune system ramping up and
Right.
recognizing that vaccine and getting ready to protect your body should you be exposed to the virus naturally. So it's not that you're infected, it's just that you don't feel good. So I think that one in particular, I hear a whole lot. The other one, kind of what we touched on already, is that, oh, the flu's no big deal, so I don't need to get this vaccine. And then more generally, with specifically the childhood recommendation vaccines, certainly, the Andrew Wakefield was the guy who published that study back in the 90s, I think it was, about the MMR vaccine causing autism. And
Mm.
his research was not really scientifically done. And in fact, he was kind of forced to go back and recant all of that. And in the scientific community, he was, professionally, I guess, embarrassed, right? But
Okay.
damage was done at that point, and a lot of parents had really leaned into that And then
Right.
even later on, you have celebrities like Jenny McCarthy that was perpetuating that myth. And so even though in the 2020s, we think, oh, it's common knowledge, right? That's not true. That doesn't cause autism. Um, I still kind of, even if the parents don't come out and say it, I still kind of feel their hesitancy, and
Right.
maybe that's why they don't want to get their child the vaccines. Um, you know, a lot of times when I have parents that are, so the term we use is vaccine hesitant.
Mm-hmm.
And so if I'm seeing a newborn or a 2-month-old or a 4-month-old, and I say, okay, and they're due for these vaccines today, the more commonly what I see is, oh, well, I want to get this one, but not this one, right? And
Right.
as opposed to, oh, I'm not getting any of them. And certainly, rarely I do have the latter. And so my approach to that is to say, number one, look, this is your choice, absolutely. Number two, I'm your child's doctor, and it's my job to advocate for, what I think and what the scientific community thinks is the best for the health of your child. So let me tell you about the benefits of the vaccination, and what are the potential risks, side effects, and these are all, very small. And then ask me questions or tell me, why is it that, what are your concerns? And very rarely do I have someone that, outside of the flu shot, that gives me anything kind of concrete as a concern. They just say, I just don't want to.
Mm.
Or I read somewhere, or I don't
Yeah.
trust the government, and I've seen more and more of that lately.
Yeah. Yeah.
And so my approach is, look, I want you to go home and do some research, right? Let me give you some good places to go on the internet to look. And one thing that I always recommend and that I teach my own kids is the idea of lateral reading, right? So if you're reading whatever on the internet, open up another window, look up that same thing from another source, and hey,
Right.
do these things match up or do they conflict?
Mm-hmm. Yeah. Replication is, it's a replication of studies. It validates, the results. So yeah, that is so true, that if you have at least two or three articles talking about the same thing, then you can at least start thinking in one direction. I know.
Right.
um Before we head off into other viruses and other forms of flu and stuff, it made me think, especially during the early days of COVID. um, we children were not so children, and I'm not sure if this applied to infants and toddlers, but the vaccines were first catered to the elderly because of the comorbidities and things like that. And the children were thought to have more uh, better immunity when compared to adults. But given that children are more susceptible to these kind of diseases, especially because they are not exposed to these kind of conditions when compared to probably um, young adults or people in their 20s and 30s, why do you think uh, why do you think children were not given vaccines, in the early days of COVID? Is it because the vaccines that they were given in their childhood kind of offered a blanket protective mechanism during the early days?
Mhm. So, the protection from the COVID vaccine is very specific, right? So, all of our vaccines are tailored to a particular illness.
Hmm.
In the early days of COVID, there was so much that we didn't know about it.
Right.
And I don't think it was so much that um, people in the medical community thought that children weren't susceptible. It's just that we didn't know.
Mm.
And immediately, I mean, very quickly, we had closings of schools and everybody working from home. And so the kids, we, in my pediatric group, we were told by our state health department, look, do everything that you can possibly do by telemedicine. Don't have these kids in the
Mm.
clinic. You don't need to. And so the kids weren't going anywhere and the parents weren't going anywhere. So the kids weren't getting sick, and not just from COVID,
Right.
but from all of the other kind of routine sort of stuff. So RSV is an interesting thing where we actually saw the pattern, the seasonality of RSV shift from
Right.
a wintertime to we had a peak in July, and it was like, what is going on here? So I don't think it's that we thought that they weren't susceptible. It's just that we didn't know. And as
Mm.
a pediatrician and probably more so as a parent, that's what really frightened me, was that I didn't know. I didn't know how my kids. So back in 2020, my kids were, to do math in my head here. They were like 6, 8, and 9, I guess at the time, 9 or 10, and so they all came home from school and didn't go back the rest of the year, and we stayed at home. I was really the only person that left the house for several months. Much to the frustration of my wife after a while and my kids, and I think my response was, well, I don't know how to protect them besides like having like a zero tolerance policy, right? I don't know what's
Mhm.
going to happen if they get COVID, and I'm not willing to find out. Now, I think the vaccines were first uh, approved for adults for various reasons. Generally speaking, new medications,
Right.
new vaccines are going to be given to adults first because as a society, we're very protective of our children.
Ethically, yeah, yeah.
And also that I think, we needed adults to be able to get back into the workforce and be able to
Mm.
participate in their daily lives more so than, the impetus to get kids back out into the world and back into school. And so while the adult vaccines, look, all of the vaccines for all indications were approved quickly, but the adult ones came first, and I think there was just some hesitancy to just in the general public, even the adults who got the COVID vaccine themselves, to say, okay, well, I feel comfortable giving this to my child. So,
Mm.
getting the FDA approval and then the CDC and the ACIP to give the recommendation for, first it was, I think, 16 and up for the kids, and then it was
Right,
12.
right.
Um, so, and then especially, I think there was a lot of regional discrepancy. I live in Louisiana, so in the deep South, I think there was a lot more hesitation for even adults to get vaccinated.
Mm.
So yeah, it was as much as it should not have been a political and polarized
Right.
conversation, it very much was.
Yeah. Yeah, we had too many experts on this. Speaking of, RSV that is doing rounds in the
Mhm.
last 2 3 years. Now, how is RSV different from the regular influenza?
Yeah, so look, it's another respiratory virus, but
Right.
it's completely different from the flu. Now, a lot of the um, clinical the presentations are very similar to flu or the common cold. Um, sorry, I just lost our the window with our video. I'm sorry. Hang on one second. There we go. Sorry.
Yeah.
Um, so RSV is a very, very common virus, and it affects. We mostly hear about it in terms of children or babies,
Mm.
but really anyone can get RSV. And then the people who are most susceptible to it are young children, elderly adults. So
Mm.
within the last year or so, there was a vaccine, or rather immunization, we'll come to that in a second, developed for people, elderly people. I'm not an old person doctor, but I think it was 65 years and up. It was recommended for them.
Right.
Um,
Right.
and so people who are otherwise healthy, slightly older kids, healthy adults, if you get RSV, you don't know if you've ever had it because nobody's testing you for that. It feels like a cold, runny nose, maybe
Mhm.
some fever, cough. It's essentially indistinguishable from an upper respiratory infection or a cold.
Mm-hmm.
As a pediatrician, where we see it kind of do the most damage, if you will, is again in young kids, especially in infants. And so I'll pull up some statistics here, but in the first year of life, about 1/2 to 2/3 to kids will be infected with RSV. I mean, that's a huge amount, right? In their first 12
Mm-hmm.
months.
Wow.
By age 2, it's nearly all. I think the quote is 97%. So kind of like the flu, most kids who get this, they do just fine. However, the complications can be very severe. And so when I talk to parents about RSV, I kind of break it down into kind of 2 clinical presentations. So it's going to start off as what we call an upper respiratory infection, which is indistinguishable from a cold. So snotty nose, runny nose, cough, fever, that sort of thing. In some children, it moves from upper respiratory to down to the lower airways and causes inflammation in the lungs. And we call that clinical syndrome bronchiolitis.
Mm-hmm.
And we used to treat bronchiolitis just like asthma because it sounded, kids would wheeze, they would have respiratory distress. And so about 2.5 to 3% of all infants or kids less than a year old who get sick with RSV will require hospitalization. And 2 to 3% doesn't really sound like a big number until it's your kid or your nephew or, someone that you know. Now, the scarier number is that about 25% of those kids will require admission to the pediatric ICU for more intense therapy, like other modes of supplemental oxygen delivery. And then on the extreme end of that, you have ventilators and things like that. And this is the statistic that really gets to me, though, is that 80% of the children that are hospitalized with RSV are, quote, normal, healthy kids. So they're not the kids that have extreme prematurity or lung disease or heart problems. They're full-term kids that don't have any medical problems.
Right.
And so up until this year, this season, the only preventative that we had for RSV was something called pazilivimab, which was an extremely expensive, thousands and thousands of dollars per dose, and had to be given every month for once a month, every month throughout the season. So the only children who qualified for this were kids who were born very prematurely, and then certain other categories, kids that have what we call cyanotic congenital heart disease or certain lung conditions. So a very small percentage of your general, otherwise, all the other infants that are born. And so the amount of hoops that you had to go through to get, if you had a patient that qualified for it, I mean, like a novel worth of paperwork of filling it out and hoping that the insurance company is going to agree with it. And then these vaccines are so exotic that almost no pediatric clinics will stock them. So then you have to contract with a pharmacy that's going to get them and then deliver them every month. And then the child has to come back every month. And so over the summer, the FDA approved nirsevimab, or the trade name is called Beyfortus, which is an RSV immunization that is indicated for every child less than 8 months during their first RSV season. And it's a one-time dose. It's expensive when you think about vaccines, on the order of several $100s, but not several thousands of dollars. And again, it's a one-time dose. So any child that fits that age requirement that's, during the RSV season is eligible to get it. And then the kids, and the way that I think about it, the kids that were eligible for the first vaccine that we had, So the kids with extreme prematurity, heart problems, lung problems, they can get it up to their second season if they have those specific health problems.
Mm-hmm.
So, and then the other thing that happened almost at the same time, I think right before, was the development of an RSV immunization for pregnant mothers. And all of this came out and like, right before the season. And I think there was a lot of, we didn't have a lot of time to prepare the general public for it.
Mm-hmm.
And honestly, I'm surprised that nationwide anyway, there was a huge demand for it. And I was, based on all the things that you and I were talking about earlier in the COVID vaccine, I was like, I'm not expecting a lot of parents to go for this. Now, regionally, again, there's a lot of differences. In my in all the clinics that we have in Louisiana and Mississippi, we've had a pretty abysmal uptake of it. But
Mm-hmm.
again, nationally, been a lot of parents that want it, and unfortunately, the company that makes it really didn't prepare
Yeah.
for the demand. So getting it has been problematic. And I'm
Is this
hopeful that next season we're going to be much more prepared, and we'll have the chance to educate the families more going into next winter.
I think this is a good problem to have, like when the demand is more.
Right,
Um,
absolutely.
is this also so we were talking about how RSV is how people the elderly are also prone to RSV, right? So it is the other end of the population.
Mhm.
Um, so is this the same vaccine, or was this the same vaccine but with a different dosage given to these older patients as well?
Okay, so the pediatric vaccine, so and we're splitting hairs here, but so it's an immunization, right? It is
Oh, okay,
it's well, it's a monoclonal antibody, which most of the people
right.
are familiar with this because of the monoclonal antibodies that became prevalent in treatment of COVID-19.
Hmm.
So it works differently than what we would conventionally think of as a vaccine. So basically, what we're giving them is what we would call passive immunization. So instead of stimulating the body to make the immune system to make antibodies
Right.
against the virus or whatever you're protecting against, we're kind of skipping that step and just giving the children those antibodies.
Mm.
Um, doesn't really matter though, right? So immunizations protect against viruses and bacteria. Um, I would be lying if I told you I knew how the adult one works. I think it's the same
Okay.
thing,
Okay.
but they're made by different manufacturers.
Okay.
Yeah,
So yeah,
I'm pretty sure it's the same concept though.
okay. So, but it's essentially these vaccines are available both for children under two and
Hmm.
a little over that, and also for the older adults. Okay,
Right, and then
um,
pregnant women.
and pregnant women. Yes. Um, Another thing that is probably a lot of I see a lot of this a lot of people talking about this on social media. Another reason why I've heard a lot about HPV in the recent past is because in India, where I'm from, people I think this vaccine is now available for the general public. So so yeah, there's a lot of um, conversations. There's a lot of chatter on social media as well. So I want to talk more about the human papilloma virus, how common it
Yeah,
is, how it spreads. Is it gender specific?
yeah. HPV is extremely common.
Hmm.
It is so human papillomavirus. It's a group of viruses, and it is what we call an epithelial virus. So
Hmm.
it can spread by what we call intimate, just skin to skin contact. So a bit of a misnomer in that it is the most common sexually transmitted infection, but you don't actually have to. Sexual transmission is not required, right? So it is extremely ubiquitous throughout the entire population of the world. Most people
Mm.
will get infected with one of the strains at some point in their lives. So a couple important things about that is that the clinical manifestations can range from asymptomatic infection that the body will clear on its own to warts, genital warts, and then certain types of cancers.
Mm.
And so that's why we vaccinate against it is the cancers, right? And
Mm.
so it is not gender specific. Now, the kind of say misconception that it is really comes from a couple of things. So one of them is that we hear most commonly about the clinical effects in women that have an abnormal Pap smear, which eventually might lead to cervical cancer. But it can cause many different types of cancers in men and women. So head and neck cancers, right? So throat cancer, oral cancers, anal cancers, penile cancers. Now, the only one of out of all of those that we can actually screen for is cervical cancer with Pap smears.
Mm.
So in men, there's no screening for any type of the cancers that it can cause. I'm going to give you just some statistics here. So, yeah, more than 80% of the American population will become infected at some point in their life. And again, those infections range from clinically asymptomatic, all the way to causing certain sorts of cancers. There are 14 million new infections every year just in the United States. And again, most people don't show any sort of signs when they become infected, so they don't know they have it, and that really complicates the transmission. And so, as I mentioned earlier, there's a range of clinical outcomes that can happen. And so certain strains of HPV are what we call high risk, and those are the ones that cause cancer.
Mm.
So there are now known to be 14 strands that are high risk, but two of them, HPV 16 and 18, cause almost all of the HPV related cancers. And so those two in particular are targeted by the first HPV vaccines that came out. And then currently we have what's called HPV 9, which the 9 is for the 9 different strains. So it covers the HPV 16 and 18, which again are the two most common high risk strains, and then also the ones that cause things like genital warts. So it's very important, not only for women, young women to get vaccinated, but also young boys as well.
Mm. What are the misconceptions about HPV and about the vaccines that we get to hear, or are there any apprehensions even for this?
Yeah, this one in particular, I think, yeah, I hear a lot of, so I have a lot of parents that come in and they're fine with any other routine vaccination. And then when it comes to this one, I can see it, I can, in their face, I can hear it in their voice.
Hmm.
Um, and so what the things that they say is, oh, it's so new. Well, it's not that new. It got approved initially in 2006. Or, well, I have a son, my boy doesn't need it, right? Because they're thinking cervical cancer.
Hmm.
Um, but
Right.
in my experience, these are the things that they're saying, but what I'm feeling, what I'm reading into it is that a lot of parents sort of feel that, hey, this is a sexually transmitted infection. And if I give my kid a vaccine for that, that's like a green light for them to go out and have sex.
Hmm.
There have actually been some really high powered studies that looked at this and that have shown no statistical difference in kids who receive the vaccine, that they will start or have what we call their sexual debut any earlier than the kids that have not gotten the vaccine. And then the same thing for the incidence of what we call high risk sexual behavior, so multiple partners and things like that. So there's no difference there. And look, I get it. I'm a parent. I understand that. I don't want, my oldest is 13. You know, I don't want them having sex before they're mature enough to understand all of the ramifications, physical, emotional, getting someone pregnant at a young age. But I also don't feel like that this vaccine is going to be, oh, okay, cool, I can go, go out and have sex.
Mm-hmm.
Um, and then, to address some of the other ones. So again, we kind of already talked about this, but the fact that boys don't need it that's not true. Boys can get, and in fact, about 40% of the cancers that are due to human papillomavirus are diagnosed in boys. So almost half, right?
Yeah.
Um, and so it was approved in 2006 for adolescent girls. And then I think about 3 years later, they looked at the data and they saw the decrease in the amount of like precancerous lesions on pap smears and things like that. And it was very, very effective. So the FDA and the ACIP said, hey, look, we're going to approve this for boys. I think that was in 2009.
Hmm.
So the American Academy of Pediatrics actually recommends that we start offering this vaccine at age 9 for both boys and girls. If you look, I think the CDC says 11, but you can give it at 9.
Mm-hmm.
And so that's the other thing, is that 9 just seems so young. And again, if you're looking at it through the lens of, oh, well, this is a vaccine to protect against sexually transmitted infections, my 9-year-old doesn't need that. The reason that we recommend it at that age, so 2 reasons really. Number one, that's how prevention works, right? You give the
Right.
vaccine before they're exposed to it. And again, it's transmitted not just by sex, but close skin contact. So
Right.
if you can protect someone before they're ever exposed to it, all the better. The prevention is going to be that much better. And then the other thing is that a lot of the data has shown that younger kids respond more vigorously to the vaccine, so their protection is better and longer lasting. And so that's the reason, if you're under 15, when you get the series, you only need 2 doses. If you're 15 or older, when you start it, you're going to need 3. So that's, kind of another bonus. Hey, one less shot.
Mm. So can any age group of people take the shot if they haven't taken it before?
Yeah, I think that there's and again, being in pediatrics, all of my patients, typically the oldest ones I see are 19.
Mm-hmm.
Um, I'd have to look up the indication for. I know there is a cutoff in the age where it's
Okay.
routinely recommended, but then in
Mm.
certain individuals that are older, they say, "Well, look, talk to your doctor. Is it worth
Right.
getting it now?" So,
Okay. Okay. Yeah, that makes sense. Um, I still have a few more questions, but I'm gonna
yeah,
jump into one of my favorite topics, science communication, which I think we share that in common.
yeah,
Um, I enjoy reading your articles that you write on a wide range of topics on LinkedIn. I find them wonderful because they are, they're personal, they're vulnerable, and they're very relatable, which I think strikes a chord with a lot of, parents, I guess. Um, so I'm going to link your articles, or I'm going to put your LinkedIn
oh,
in the
great, yeah.
description so people can go and read. But briefly, what got you into science, like science writing or communicating science? I know you do that for your for your living, but
Mhm.
what got you into writing and storytelling?
Yeah. I've always loved writing, and I said earlier, when I was in high school, I was very science oriented.
Mm,
Um, but also, I've always loved reading, fiction and writing, and, it's something that I think that I excel at.
mm-hmm.
And so that has always come, somewhat naturally to me. And the idea of teaching is sort of ingrained in the way that doctors are trained. So in
Right.
residency, there's a very, there's a hierarchy. You have the medical students, at the bottom of the team, your intern or your first year resident, and then your more advanced residents. And then at the top is the attending physician or the staff physician. And so the way that learning, ideally in a residency program works is that everybody's sort of responsible for teaching that lower rung on that ladder, if you will.
Right.
And I found, I was exposed to a lot of different styles of teaching as a med student, as a resident, and some of them were not very good, and some of them were, really good. And so, that kind of rubbed off on me. And then, as I mentioned to you, my first, so I graduated residency a little over 10 years ago. The first 7 years, I was a pediatric hospitalist. So I was taking care of the kids in the hospital. I wasn't seeing them in the clinic. And then I had another kind of part-time job with one of the rural family medicine residency programs, where I was the attending physician and I was rounding on patients with the residents. And I, now that I say I've been out for 10 years, it really makes me feel like, wow, I'm getting a little bit old. But I've always felt younger than I think my chronological age, and really identified with these younger doctors that I was working with and teaching, and really found that I enjoyed kind of informal teaching, on our rounds at the bedside, of really trying to break down topics into, kind of short presentations that are easy to digest. And when I kind of thought about it, well, that's what I was doing. That's what I'm doing every day when I see patients, whether it's, a teenager or their parents or both, trying to explain, okay, this is why your child's in the hospital, and this is the diagnosis, and this is what we do for treatment. And so now I've gone back and started working. So in addition to administrative work, I'm still seeing patients regularly in the outpatient clinic. And I tell, all the providers that I work with all the time, if I walk out of the room and the parent still has questions, then I haven't done my job. And taking that extra minute or two, and sometimes it's more than 2 minutes, but to really sort of meet that person where they are and explain to them, this is what's going on with your child. This is how we're going to treat it. These are the things that I want you to watch out for, and to call us or to come back if XYZ happens. Because I've been in the situation where a child has come in after being diagnosed with whatever by someone else, and the parent just they really don't know what's going on, and it's not their fault. It's just that whoever was charged with that either didn't take the time or didn't speak on their level. And one of the things that really used to bother me in residency is so the way that it worked is you would come in the morning and see the patients and do what we call pre-rounds and what happened overnight, and these are the labs and these are the vital signs. And then the team would round together with the staff or attending physician on each patient. And it was rare, but I would have attending physicians that would come in and talk to, if I was on the medicine side or the pediatric side, talk to the patient or the parent like they were talking to another doctor. Your child has this, we're going to put them on that. Okay, goodbye. And so many times I could just see the look in the parent's face, like, I don't know what you're saying, but I'm so intimidated, I'm not going to ask questions. And so I found that I was spending time in the afternoons going back to the patient's rooms and saying, hey, what questions do you have? And that sort of thing. So I really became interested in that, just, kind of organically. And then my experience during the pandemic, as I mentioned earlier, I just spent a lot of time, like talking with friends, acquaintances, family members. At one point we had an electrician at our house doing some work outside of the house, and my wife actually had a breakthrough case of COVID. This was during the Delta surge. And so I met him at the door and I said, hey, look, let's go outside on the porch. I'm not sick, but my wife is. We're going to stand far away from each other. And he was kind of a little bit like, oh, what, but he started asking me questions and started
Mm-hmm.
asking me really good questions about the vaccine. And, this guy and I were from very different walks of life, and we spent an
Right.
hour having this conversation. And he left and he said, look, I appreciate you taking the time. I'm still not sold that I'm going to get the vaccine, but I'm going to go home. I'm going to talk to my wife. I'm going to think about it. And there was a lot of sincerity in his voice. And so that really inspired me to sort of get more involved with public health and that end, and then communication.
Right.
The articles that I write for LinkedIn, a lot of them have come from stuff that I've written for my current job as the chief medical officer of my company, where a,
Mm-hmm.
a large portion of my time is spent doing education. We have a lot of nurse practitioners that work with us, and they're very capable, but they don't have the same training that doctors have going through residency. So
Right.
every Friday, I send out what I call my Friday email, and I'll say, hey, look, I saw, whatever, really bad case of eczema in the clinic this week, and kind of just brushed up on, the latest in treatment. And I want to share that with you guys. And so, did my best to kind of, brevity is usually not my strong suit, but try to condense it down into one
Right.
document, and then always here's some links to read more about it. And so a lot of the articles that I published on LinkedIn have come from that information that I've sort of
Mm.
tailored to be more towards, directed more towards, people who don't work in the medical community or parents.
Yeah. Yeah, they're very easy to read, and especially I think and they're also very succinct. So other when I read, it's probably like a 4 or 5 minutes read. So I know the gist, and it's easy for me to remember. So um, actually, when I was reading through the articles, there were three of them that stood out for me, and I thought I'll discuss that briefly. The first one was about gun safety, and now what I found it fascinating because I didn't know doctors spoke about that. So like primary care practitioners. So so you talked about the importance of primary care practitioners or doctors to have this conversation. Is this actually your responsibility, or is this something the doctors have taken up for the greater good?
Yeah, I mean, I think it is our responsibility from an educational standpoint.
Hmm.
Um, it's not something that, at least when I was in training, was like, okay, now we're going to do our training on gun safety. And my hope is that now certain institutions are leaning more into that, because um, gun violence is all around us, unfortunately. And whether it's, the things that you hear mostly in the media are the really horrific things like school shootings. But,
Hmm.
there was, in the last 6 months or so in my state, a child who died because he was at a friend's house, and it was, oh, hey, here's my dad's gun. And they were essentially playing with it, and it went off and killed a young child. And so I'm a huge advocate for, common sense gun safety laws. And, and I put in that article, it's kind of an uncomfortable conversation to bring up sometimes, especially in the deep South, where, I think compared to a lot of other parts of the country, there are a lot of people that hunt and have guns in the home for that, or have, handguns for personal protection.
Yeah.
And so um, I think it is a responsibility of, especially for pediatricians. We talk about, hey, your child needs to be in a rear facing car seat, right?
Right.
And, wearing bike helmets, and, hey, these are questions that we ask. Hey, is there anybody in the home that smokes, inside the home, outside the home, in the car? So this should just be another one of those questions. Hey, do you have any guns in the home? And, so, no, nope, we don't. Okay, cool. Or some people don't want to. They think that it's none of the doctor's business, and I
Hmm.
understand that, but So I always encourage, our doctors to come at it not from a judgmental standpoint, but from a curiosity, right? And really trying to give them, and if they don't want to have the conversation, there's really not much point in going beyond that, right?
Mm-hmm.
But trying to have an open-ended conversation of, look, the recommendations, the safest environment for your child, if there's a gun in the home, is to have it locked up and to have the ammunition and the gun stored separately, right? Um, Another thing that I started thinking about when my kids were younger is going over to friends' houses and, hey, do the parents have guns, right? And that could be an awkward conversation too. And one thing that I have always told my boys is, look, we don't touch guns. And if you're at a friend's house and he says, hey, let me show you my dad's gun, you say, no, go tell an adult, tell them to call me, whatever, like,
Mm.
because accidents happen.
Right.
So it's another one of those things that unfortunately is sort of a political deal, when safety should never be something that's polarized, politically.
Hmm. Yeah, that's interesting. I never like I understand the other side of it, but when I read through it from a medical practitioner perspective, I found it very fascinating that that doctors also talk about this, and I thought that was very interesting. And the second article was the importance of everyone learning CPR, and
Mhm.
um, it is quite essential because we've seen this in real life or in the movies as to how often people, have an attack or they need that. So if as a general audience, if someone's interested in getting trained, who do they go um, to
Yeah,
get
I mean,
that
so there's a
initial step?
lot of resources that you can find. The American Heart Association is
Right.
one. Just in your community, if you just Google, YMCA's will give courses.
Mm,
Um, I'm a big, like you said, a big proponent of really everyone should learn it, but also just even learning some of it, right? So the article I wrote
right.
was an experiment I did teaching it to my kids who were at the time, I think 5, 9, and 11. And so I have had people ask me, hey, look, how old does my kid need to be to take a class and get certified? And I've seen different ages recommended, and the first one is your child needs to be cognitively able to kind of understand the concepts,
Right.
and then also physically able to do chest compressions. um, but my point in that article was that even if my kids just know and understand a little bit, maybe that little bit is enough to save a life, right? And so the clinical scenarios we went through, were, hey, you guys are playing in the neighborhood with your friends, and somebody falls off of something and hits their head, or whatever. So the things I wanted them to be able to recognize is that when a child or a person is in trouble, meaning unresponsive, right? Maybe they don't need CPR, right? They're not in cardiac arrest, but they're
Mhm.
unconscious. So the idea of um, calling for help, going for an adult, if you have a phone, calling 911.
No. Yeah.
And then, in the last many years, there's been a push towards what's called compression only CPR, right? And I think a lot of people kind of are like, oh, I don't want to give mouth to mouth, right? Um, just doing those chest compressions has been shown to be equally effective as what we would call traditional CPR. And some studies
Mhm.
have shown that it's more effective. And, the way that I explained it to my kids is very simply like, the heart is a pump. Our body needs oxygen, which is carried through the blood. And if the heart stops pumping, then what you can, the one thing that you can do outside of a hospital is to, literally doing chest compressions makes that pump start working again, and doing
Mm.
them at the correct speed, and the correct force and depth into the chest is what will keep your brain perfused, right? And so that's really what, keeping the heart and the brain with blood flowing to them to keep the oxygen going, so that when EMS comes, they can do things like put on an AED and give drugs and things like that.
Mm. Yeah, no, I think that's really important, and I know most colleges offer it, but if people are interested, they could probably go to the community services or
Yeah,
the
and I can
American
send you some
Heart.
links after this that we can
Yeah,
post there too.
yeah. I'll link the links below. We're almost heading to the last segment, so it's called
Okay.
Dig Deep, where it's something like a rapid fire. So it's just very
Okay.
short questions that you can think of, just to end in a fun note. The first question is curiosity or passion. What's your pick?
Oh, that's a hard one.
No wrong
I'll go.
answers. There are
Yeah,
no wrong
I
answers.
mean, I think curiosity leads, in a lot of instances, for me, to passion.
Okay. What does failure mean to you?
Opportunity to learn and to refine my approach.
What keeps you going?
um, my family, my wife, and my sons, um, just in general. And then what keeps me going on a professional level, because some days it's hard, is those interactions I have with kids where um, I come into the room and they don't want to even look at me. And then by the end of the interaction, I'm getting a high five and smiles, and the parents are saying, "Oh, he's never had a visit with a doctor like this before."
Hmm. So yeah, that's a good feeling. What is your vision?
It's my vision. Well, I have really increasingly become very, very interested in health and science communication. At the same time, public health and health equity. Um, a lot of the patients that we see in our 21 locations are in rural areas. So really trying to work to get everyone the same opportunities to live a healthy life.
Okay, the last one. I think I know the answer to this, but I'm still going to ask you this. Jonathan Heyman, the pediatrician or father?
Father.
Okay, yeah, I knew that. uh, it was wonderful talking to you, Jonathan, and
Yeah, it was really fun.
I
Thank you so
um
much for inviting me.
no, it was my pleasure, and we spoke so much about the viruses and like the importance of vaccinations and basically the fear and the misconceptions. I really hope people take good points out of this, and that's the
Yeah,
whole point of us talking and discussing. And yeah, I'm gonna link if you can send me your social media links as well,
yeah,
I'll put that in the description, and if people have any questions they can reach out to you. But thank you
yeah,
once again
absolutely.
for talking to me. It was wonderful having you.
Well, it was my pleasure. Thank you for inviting me. So.
The pleasure's all mine. All right.